Oh, I'm seeing some names coming along the top. I recognize some of them. That's great.
Absolutely. What a crowd. Fantastic. Well, welcome to Afternoon Tea with Docs. I'm Dr. Linda, emergency medicine physician from Sheffield, and I'm here with my lovely co-host, Dr. Erica, a GP from the West Midlands. And we are both lifestyle medicine physicians. And as we are talking about lifestyle, I cannot not give a shout out to my sister who is just giving birth right now. So you go, sister. I'm here for you. Well, we have wonderful news. Also, we have partnered with the Dandelion Seeds Foundation, a charity, to bring the prestigious Complete Health Improvement Program free of charge for the residents of the West Somerset and Taunton Deane area in the UK. You can now sign up on our website for the next program that's starting very soon. Date will be announced. We host afternoon tea every Sunday at 5 p.m. And we cannot wait to share these teas with you in the future. We always share 3 actionable thoughts from our speakers that you can implement in your life right away to start achieving your health goals. You can chat directly with our guest experts here on Zoom or follow us on live stream via Instagram, Facebook, and YouTube. If you are ready to implement your life goals, join our free membership on our website to be part of our supportive community to set you up for health success.
Today, we're so delighted to have Dr. Rob Lawson, founder and chairman of the British Society of Lifestyle Medicine, join us to talk about some of the wider factors that affect our health. Having qualified in medicine in 1975, Rob has gained extensive experience as a GP in Scotland. His principal interests have been primary and secondary prevention of disease and the specialty of lifestyle medicine, as well as leading his NHS team to the highest RCGP awards for quality from 2003 to 2013. He also founded a charity in 1991, providing weekly activity and support in venues around East Lothian for sufferers of long-term conditions, including heart disease, type 2 diabetes, stroke, lung disease, frailty, and more recently, long COVID. He has retired from his NHS practice to concentrate on the applications of lifestyle medicine to healthcare. In 2016, he co-founded BSLM, a British Society of Lifestyle Medicine, a registered charity to promote the principles of lifestyle medicine to healthcare professionals and the public. He is president of the European Lifestyle Medicine of the government.
Oh, Erica is having a little bit of an internet problem.
You don't want to hear the rest. There's nothing interesting there anyways.
Oh, welcome. Hello, Rob. Thank you so much for joining us today.
Lovely to be here, and thank you for the great privilege to be here, I can tell you. Thank you very much.
Well, as Tara just said in the chat, your resume blew the system. I think she's right.
Wow, it certainly has. So thank you so much for coming today, Rob. And you're one of the founding fathers of lifestyle medicine. You have dedicated your life to bringing evidence-based lifestyle medicine into the lives of both of our patients and healthcare professionals. That is changing the trajectory of medicine as we are going forward. And before we fast forward into talking about lifestyle medicine, we would love to know how it all started for you. When did you realize that you wanted to become a doctor?
Gosh, that goes back a long way, Linda.
Yeah.
To be honest, I think it was probably planted in my head by my mother in particular. I think that she clearly saw something in me that made her think that I should be a doctor, because I think from a very young age, I remember her saying, oh, he's going to be a doctor. And I thought, well, okay, so I better do what my mother tells me, become a doctor. It's curious, I was thinking about it earlier, because why do any of us become doctors? If it isn't because of some intuitive desire to help other people. The old term for, well, doctor really means teacher, doesn't it? It's imparting knowledge and so on and so forth. So I was told, because I was brought up abroad in quite a poor environment, the people I played with in the streets were, poor in terms of financial poverty, and here was I, sort of, relatively wealthy, well-off, from a well-off family, but they accepted me to play in the streets with them, and I thought nothing of it. But apparently, I used to give away my clothes and my shoes, which annoyed my mother a lot. I don't remember doing it, but so maybe that's why she decided I should be a doctor.
Oh gosh, that's a beautiful story. And I suppose those memories with those children have left a really large impact in you.
Well, yes, I think that, I was one of these people that was brought up abroad. I'm a Scot, and I was sent over when I was about 10 or 11 to this country to get an education. But I was abroad in a country called Turkey, as it happens, in a city called Istanbul. And I was born and brought up there. So it was my home. And of course, in those days, back in the early 50s, it wasn't a developed country. Whereas back in the UK, in the post-war years, people were subject to rationing, for example, in terms of their food. Out, obviously, where I was, there was no rationing, and I had abundant access to fresh, locally grown fruit and vegetables, and the markets were always full. So never had any problem in terms of finding good food. And of course, the environment was very different, and I think that the society was very different. Although Istanbul was very cosmopolitan, you just stepped outside the city into a very conservative part of the world, where women had to hide under shawls and weren't allowed to speak to their men, and so on and so forth. So it was an experience. Naturally, I think we're all shaped by our experience, aren't we? And it was an important one. And it followed me through, because when I was qualifying as a student doctor, I actually went back to Eastern Turkey, to the border with Syria, and worked for a while in one of the mission hospitals, as it happened, out there, which is run by Turks. And again, you saw things that you would never see in a developed country. You saw sickness, you saw terrible poverty. You saw the impact that had on the population. Families would walk for miles and miles and miles to get to the hospital so that we could immunize our children, vaccinate our children. And of course, we didn't have equipment that was a one-use and throwaway plastic. And if there was anything plastic, it was reused. They tried to sterilize them. And again, that kind of influenced my impact or my opinion of the National Health Service. How lucky we are to have it, and how important it is to keep it. And that is, I think, to some extent, has colored a lot of how I think about the NHS as well, having experienced healthcare system outside of our own country. Look, you're going to have to stop me. I will ramble, so you'll have to stop me.
This is such a fascinating story, though. And from Istanbul, when did you come back to Scotland then?
I think it must have been about 10 or 11. I don't tell anybody this, but I went to a girls' school, English high school for girls. And some people say that explains a lot, but actually it was a primary school, and it took in, obviously, boys like me, foreigners. It's an international school, really. And at the end of that, I went to French school for a year, but I learned more Arabic than French, I think. The person I sat next to was an Arab, so I just learned Arabic. They sent me over to boarding school over here, so I was educated privately, and that's another issue really for us in this country, that a lot of us as doctors are educated privately, and yet as a family doctor, of course, I had to grow up pretty quickly. to understand, even a hint of understanding the sort of privation that our patients have to go through. So yeah, that paints another little sort of strand, if you like, in my thinking.
Absolutely. And when did you decide to become a primary care physician? Was that something that you knew all along? Because we go through so many specialties early on, and all doctors question what should they become. But did you know right away that you wanted to be a family doctor?
Yes. I think that I didn't see that there was anything else. The continuity that a family doctor brings to families in their practice is one of the great strengths of our primary care system. And it was a great privilege for me to be in one place for 30 years and see, rather like your sister having her baby now, and then I'd actually see your sister's baby having a baby. So I think it's such a privilege to have been involved with that. And of course, it's a great leveler because you're dealing with everything from a duke all the way down or up the other way around. I know there's duke upwards, from a duke up to very underprivileged people. And I think it's a fantastic job, actually. There is a problem now, I understand, with it, but I think that lifestyle medicine can rejuvenate it and bring it back to where it should be.
That certainly has given you an insight into the importance of holistic care. And about 30 years ago, long before lifestyle medicine as a specialty was known about here in the UK or worldwide, you founded East Lothian Cardiopulmonary Rehab Group, now known as the Live Well East Lothian Group, which is still active today after 30 fruitful years and embodies the principles of lifestyle medicine. Can you tell us a bit about the charity and what inspired you to set up this charity 30 years ago before anybody has ever heard about lifestyle medicine and holistic care?
Well, thanks for asking about it. I think that it's been a tough gig actually keeping it going for that long, but it started out through this notion of prevention that my grandparents used to say, prevention's better than cure, and a stitch in time saves 9. I don't know if many people understand what a stitch in time saves 9 means, but it seemed very natural anyway. And what was striking to me is that people who had heart attacks, and in those days, there seemed to be a lot of people having heart attacks, that they were just chuffed out of hospital and nothing much else happened. But one of the, locally in Edinburgh, we were lucky in that I think the first community rehab consultant was established for cardiac rehab, and based in Edinburgh. And she was attempting to set up the cardiac rehab unit. What I found is that people where I lived, and it was only 17 miles away from Edinburgh, didn't want to go into Edinburgh. It was too much trouble. So the obvious answer was to try and get it local. And I had been fiddling around with fitness assessment clinics. I'd sent up a lifestyle active management program, which I called LAMP. And it just seemed a natural extension then to try to go outside my practice to create this entity where people could get access to local access to a gentle exercise, to that mutual support that comes with being in that environment, and also relaxation. We had a relaxation element of it. And for a long period, we had the sort of group consultation approach, where it was mainly a question and answer session, but I knew everybody there because I admitted them. And we sat round we stood round in a circle, and people would just raise issues or concerns that they had. And as we would talk about it with the cardiac nurse and so on and so forth. And the striking thing about it, and one of the reasons that kept me going, was how happy people were, that the laughter. If ever I felt a bit down because I was having trouble getting the money to keep it going, I'd just go to one of the classes. And, it was such a laugh. People were happy. It's extraordinary, the power of that kind of group effect. And one of my memories actually is quite early on of a 30-year-old who had had a heart attack, and he came tentatively to the door. I was actually standing behind him as I was going in, and he seemed to hesitate. And I said, "Welcome, come in, come in." He came in and looked around, and the class had kind of started, and people were moving around and chatting and smiling, and he burst into tears. And I was a bit taken aback. I said, "Are you all right?" He said, "No, I thought my life was over, but I can see that I have a life now," because he was seeing all these people who had had heart attacks, who had, were happy and active and enjoying themselves. So I think that that kind of stuff isn't really measurable. So, the fact that, his blood pressure may have fallen or his waist circumference fell, how do you measure that bit of it? And I think that that's one of the irksome things about running a charity, really, is the numbers game. And identifying the quality of life in that way is very, very hard. And that's, can apply to lifestyle medicine principles anyway, but in particular to that. So here I am going on again.
That's an incredible story. And it just reminds me of why we went into medicine. And unfortunately, also, it reminds me of why we are often so burnt out by the medicine that we are experiencing right now. That laughter that you get from your patients, the satisfaction that you feel when they get better. And that's why we are so grateful to you for bringing lifestyle medicine back into our lives, because to be honest, we have been contemplating quitting medicine before lifestyle medicine has appeared to us, because we just didn't feel that we were making a difference, and going into work, hustling for 12, 13, 14 hours every day without anybody getting better in the system that we are in, feels like they have robbed something from the medical profession that is so meaningful, and is why we went into it, and why we used our whole life, every single minute of it, to be with our patients. And lifestyle medicine has certainly brought back that feeling and that joy that we see in these communities. And how did that 30-year-old do? Do you remember?
Oh, he did fine. Yeah, no, he just got better and left. I think the thing about what we went on to do was to create a sort of phase 4, if you like. When they'd gone through the 12 weeks of rehab, they would go out and join groups outside that met every week. And eventually that's what we became. So we grew to include people with all sorts of conditions or no condition. And we had, up until the pandemic brought us to a full stop, we had 17 classes every week around the county, and all of them were very well attended. So the pandemic, of course, meant we had to rethink how we provided the service, and it's been a terrible thing. This whole thing has just been terrible, but it's hard.
It has certainly affected that social connection between the patients. And are they are the groups going to go forward still?
Yeah, well, what we did was we decided to almost to rebrand, which we did as Live Well, but operated by Zoom. In other words, we opened up Zoom classes, and when we were allowed, we had what called walker size, which is not too unfamiliar to you. And so, in a couple of towns in the county, we just have a group and go around. And I got my Paths for All walker trainer armband, and we have properly trained instructors, of course. And we went out for walker size. So between the Zoom and the walker size, we tried to keep it going. But I was so conscious we weren't getting to everybody we needed to get to. It highlighted this terrible inequality that some people had access to internet, some people had the hardware to allow access, others didn't, and they were effectively being excluded. I can't see it in the obvious way around that, except to make sure that everybody has access to internet, everybody has hardware to link into it. I'm not saying that Zoom is by all means or that kind of, that's the best way to communicate. It isn't. But it's nonetheless, in that pandemic environment, it was such an important connection. Another story to tell you, so full of stories. One of the attenders at the Zoom classes, as we call them, a regular, was admitted into hospital because he had underlying breathing problems and had done for quite a while. And to my amazement, he just joined in from his hospital bed to the class. And, you know, but he said, look, I'm not feeling too great. I just wanted to see your faces and say hello. You know, I know I'd normally be there at this time. He died 2 days later. And you think he felt, you know, I had this so many times. I've had people who, and even somebody who died, the son got in touch to say, you know, she just lived for being able to come and participate in these get-togethers, the classes that you had. It kept her alive. You know, so that's the thing. You know, it brings a little bit of humanity into quite a dark world for people who perhaps are maybe very alone. And loneliness is, as we know, a very important factor.
Oh, Rob, the difference that you make in this life is nothing stopping you. And thank you so much for the incredible work.
No. I'm not taking any credit for it at all. I think this is entirely up to all of us participating.
Certainly, but wow. You're definitely giving meaning to not only healthcare professionals, but patients, and the circle goes on. We'll try to carry it forward as best we can. And about lifestyle medicine, among healthcare professionals and the public, there are quite a few misconceptions about what lifestyle medicine is. And it is actually a lot more complex than the term lifestyle conveys. As the founder and the chairman of the British Society of Lifestyle Medicine, can you enlighten us about lifestyle medicine and what it really is?
Now, I don't know, did I know this was going to come up? There are a lot of different definitions of lifestyle medicine, and this is one of the problems, and it's something that I hope I'll be able to work on. I can only speak for myself because you know, I can speak for the other organizations, of course, and I know that our definition's out there, and we have one ourselves at the British Society of Lifestyle Medicine. And I've actually got it on a screen just to my right, which I could read out to. But thinking about it, it's something more like an approach. It's something that just feels right. You know, and it gets back to that question of why we became doctors in the first place. You know, did we come just to deal with disease or illth, or did we come in to deal with wellness and wealth as well? You know, that continuum. Yeah, and where do you land on that particular continuum? At which end? And I think that lifestyle medicine effectively is bridging the gap between public health, for example, and conventional medicine. It deals with wellness. It deals with creating health. It deals with salutogenesis. I mean, there is some nuanced approaches here. The Americans might not agree with that aspect of it. But in terms of where we are and you are, for example, in being qualified lifestyle medicine physicians, you're dealing with individuals. We're all dealing with individuals. So lifestyle medicine then, lifestyle is the medicine. Yeah. And the second thing, of course, is that as lifestyle medicine practitioners, you're delivering the lifestyle medicine interventions. So I think that there's that, you know, thinking of an onion, thinking at the center of it, the core of it, there's people like you who are delivering on the principles, the 6 pillars or beyond. I have 15, in fact, determinants. And then there's the wider community. And then, of course, there's the nation, and beyond that, the world. And they're all nuanced. So I think that it's not just about you know, the medical model that we're talking about here. There's a biopsychosocial model that we are delivering as lifestyle medicine physicians, which is a very natural place to be as a doctor. But somehow that gets taken out of it when we go through training school, not just as doctors, but as nurses and pharmacists and dietitians. This is an approach that we can all embrace because it feels normal, it feels intuitive, it feels inspiring in many ways, and it works, it's effective. And when it comes to ethics, then there's really, if you think about it, we signed the Hippocratic, well, we didn't sign it, but there was a Hippocratic oath. But in terms of what ethics you choose to follow, if you follow the Beauchamp and Childers, as I do, then you've got autonomy, you've got beneficence, you've got non-maleficence, and you've got justice. Well, the first thing is actually not to do harm. Now, that to me is critical. Don't, for goodness sake, don't harm anybody. We all go in to do some good, but please don't harm people. And my first exposure to the harm bit was through a pharmaceutical company. That in my naivety, the drug rep came to see me saying, we're doing some important research on an antihypertensive to bring down blood pressure. And it turned out, well, I knew it was a diuretic, which is a very commonly used blood pressure tablet. And they were saying, we need to know more about this and how it, the effect it has in the real world and all the rest of it. And it's important research. And I said, well, I'm very keen to advance knowledge, I'll certainly participate. And he said, well, you'll get a $5 for each patient you recruit, and that will go into the practice. And I thought, okay, well, I don't see it as recruiting. I just see it as science and research. Stupid me, that it turned out that it was just the company, I won't name the company, but it is a German company. It was just simply using this tool to try and get me and other doctors to prescribe their medication, which they knew would bring them in money, and it'd be for life potentially. And that was quite arresting to me at the time. And from then on, I began to understand better how the drug industry influenced me and my fellow doctors and others. And it was fairly late on in life, actually. I read a book called Deadly Medicines and Organized Crime by Peter Goetsche, who's a Cochrane collaboration head, Nordic collaboration head. And that, again, if there are any doctors on this call, read it. And if you still think the same about prescribing medicines, I'll be very, very surprised. I felt guilty. I thought, look, I was trying to do good here, and yet there was evidence out there that I could be harming people, but nobody told me. I didn't know that. So I think that this principle of doing no harm, lifestyle medicine is built on solid rock, as far as I'm concerned. It is, the evidence is all there. It's not going to do any harm. Well, I was just thinking about this too earlier today, about not doing harm. Your physical activity, we know, does so much for us, but the process of physical activity might be an issue for some. Because I was out cycling today, and a group of about 20 cyclists, went past, and I was thinking, is there any surprise when there are 20 cyclists out there spread out that some motorists might decide to take chances, that somebody might get knocked off. So I think being exercise can sometimes bring its problems, but it's such an important element, isn't it? Another story, actually, that I tend to go the same route, and it's always on a Sunday. And I come to a T-junction, and it's badly sighted. You can't really see very well coming around the corner. And I've been doing it for 20 years. And because it's very narrow and it's a farm track and there are lots of potholes, I tend to go down the middle to turn round. And on this day, a van, in fact, was coming from the other direction. Now, it narrowly missed me. I was able to go into a field to avoid it. But the guy got out and shocked me by saying, "Next time, I hope I mow you down, you dozy bleep, 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 bleep." And I was quite shocked. I was thinking, well, he would have been all right. I would have been the one right enough, but to say that next time you do. So I think that exercise, we know, is good. No question about that. And I'm fortunate in having that opportunity to have that exercise. So lifestyle medicine brings so much to the average consultation, wherever it is. And just simply starting the conversation, whatever your discipline, whatever your background, it doesn't take much to do that. And the light bulb moments that occur throughout a career are fantastic. So anyway, I'm going to shut up again.
We don't want you to shut up, Rob. We want you to keep talking. I'm absolutely. For me as a GP, I find that these lifestyle medicine conversations that I have, whether it be face-to-face or over the phone, they're the conversations that I enjoy the most, that actually gives me some energy for the day. And you talked about these light bulb moments throughout your career. What were some of your light bulb moments?
Do you mean in terms of lifestyle medicine, or just generally medicine, or just in life?
Well, anything.
Anything, any light bulb moments.
Yeah, why not?
Right. Well, just as they occur to me, then I think I had one that actually shaped my decision about what I did when I retired from NHS general practice. I got to that great age where really I should move on, and I did. But a couple of years before, having been the lifestyle medicine, it wasn't called lifestyle medicine, let's face it, and I don't like the term, but that's what we're kind of stuck with. A guy that I knew, a patient, came in to see me and said, well, what had happened was he'd disappeared off for a holiday to Thailand. And when in Thailand, he thought, oh, this is nice and cheap to have a health screen, and I'll have an MRI scan, and I'll have this scan and the next scan and blood tests and intracellular rhubarb and everything. And he came back with a whole sheath of stuff and 3 diseases. He said, I've got arthritis, I've got hypothyroid, low thyroid, and I've got high blood pressure. And I was thinking to myself, without saying to him, well, you're very overweight, you smoke like a chimney, you drink like a fish, you don't exercise, you're sitting driving the whole day. There are things we can work on. That's what I'm thinking. But trying to engage him in that conversation was proving fruitless. And for the first time, I think I failed. That was a failed consultation, not the first time, but it was a failed consultation. And because he left, obviously pretty unhappy that I wasn't giving him an armful of drugs to go away with, and said I would look through all the data, none of which substantiated any of the diagnoses. And he went, within 24 hours, he'd gone to my partner to complain about that Dr. Lawson. All he talks about is lifestyle. And that was thoroughly depressing, actually. And I think that it was around about that time I decided that I'd use my pension pot to open a lifestyle medicine center. And it was the wrong place, wrong time, lost my money, but loved every minute of it. And that's what actually triggered me into forming BSLM, because at that stage I had befriended Gary Egger, who is one of the founders of lifestyle medicine in Australia. And he, in fact, was one of my visits over there. He said to me, he said, oh, why don't you form a British Society of Lifestyle Medicine? And I was like, don't be silly, Gary. No one's interested in that over there. I've been doing it for 30 years. But it sort of, that was 2015, I think. And I started to think about it, and having the center going and seeing how beautifully it worked, seeing all these different disciplines and therapists working together all to the same end. I had a cafe and a shop selling healthy food. It was just a wonderful, wonderful atmosphere. But it simply wasn't, the plan A of getting enough money to pay for my charity just simply wasn't happening. And plan B fell apart because plan B, not through no fault of my own, plan B withdrew from the project. So I had to close it down. But it was that knowing that it worked so well is what made me think, well, how do we get this into the National Health Service? Because that's where it should naturally fit. We should all be doing this, but within the National Health Service. And I suppose it was Lauren Stewart, a consultant surgeon, and we were talking about it, and Michael Boyle, a GP in Sheffield, that they both said, well, go for it. Just go for it. Let's go for it. And so I just went for it. It took a little while, but once we set going in 2017, I think it was, it's gradually been growing. So here, look, I've just gone onto a tangent again. Erica, come on. Keep me right.
And we are so grateful that you have, founded the BSLM, because now so many of us that may kind of have all this energy about wanting to do some, something, for example, me in my training was also getting a bit sort of frustrated and disappointed with what I was doing, but not knowing about the discipline of lifestyle medicine. And now it's given me the opportunity to learn about it, and has given me a renewed kind of, I don't know how to say it, but a sense of satisfaction with the work that I do. So thank you, Rob.
Well, can I just say that, I speak to several people every day who are thinking about, doing the certification exam and all the rest of it. What I'm seeing is that it's people at the beginning of their career who, having been through what they've been through, recognize that something's not quite the way they want it to be, rather like you're saying, and that there has to be another way. I think that one of the most satisfying things as a medic is having a satisfied patient. And we're all patients after all, we're all in the same boat, potentially. And the other group of people that I think that are people who are reaching mid-career, and they're looking back thinking, what have I been doing, for 15 years or whatever, and what have I gotten ahead of me? And so they're coming across lifestyle medicine and thinking, this is what I want to do, and so I think that it's wonderful. I think it really is so inspirational to have people like you guys doing what you're doing, because ultimately, I'm going to be in your hands as a patient one of these days, and I want you to be my doctor. So I think that we've got to put things into perspective. That we're building a future here, and one of the things that Linda mentioned earlier was the challenges that we face, and one of the biggest challenges is within our own profession. I've been faced with it for 30 plus years. A lot of my colleagues don't see this as a medicine thing. It's not part of the remit. That's changing, evidently, by our membership and so on. And of course, there are some academics who just think that it's all for middle class, well-off people and not for everybody, which is completely wrong.
I actually, that's really interesting, because talking about challenges with our colleagues, I recently went to a conference on obesity, and how to consult about obesity, and one of the things that kind of made an impression on me was that how many doctors don't see it as their job to do this, because it's not so prestigious as a condition, and I thought that was just a really interesting thing, that there was actually some studies on that, to say that within our profession, people see diseases, that there is a hierarchy of disease where they see some as more prestigious than others, just like they would with specialties. And they probably view, cardiothoracic surgery, neurosurgery, as a more prestigious career or a specialty than, for example, general practice. That was just really interesting to me. I don't know whether you've come across similar viewpoints yourself in your career.
I think the word you were looking for is sexy. There's nothing sexy in dealing with obesity. I think it's same with lifestyle medicine. I think I've come across some interesting things. I think that when trying to get the shared medical appointments or group consultation thing going in the UK, I was started up here, and trying to get academics interested in it was just non-starter. I think that unless it was going to end up in a high impact journal someplace, they didn't think it would, so they will not get interested in it. Eventually, in fact, it was Sir Harry Burns, our former CMO, who said, just do it, just get on with it. Don't wait for pilots this and pilots that, just do it. And of course, it's spread all over the place now, not due to me, but it is now taken off. So I think that obesity, the canary in the coal mine, I think I part company with some people in this. I don't see it as a disease as such. I think it is very much the environment which has created this. And it's something that we have to uncreate, when we can at individual level, clearly. I can't understand why people would not be interested in obesity or being overweight when we know, especially in the pandemic, people now are not disagreeing, that if you're overweight or obese, you're at greater risk of dying. It's that important. It's that, I don't think we can run away from this. And in terms of the profession and others, I mean, there is evidence, isn't there, as I think you're alluding to, that if you yourself are overweight, you are not going to bring the subject up. You're not going to start the conversation. And sadly, a lot of us are. So I think they were kind of missing a trick there. But in terms of obesity, there is low-hanging fruit there, and we at individual level we can make a difference. But one of the reasons I think why many of our colleagues don't want to get involved is because there's not much choice for them. They've not been given the training, they've not been given the information, and if they were, there's nobody around that can help. And I think this is the frustration. So the confidence and competence of the person who's delivering the healthcare is critical, which is what we are trying to do in the society, is to provide that confidence and competence to get involved, to start the conversation, and be able to signpost people into the right areas to achieve a better health outcome for them, for people who are maybe obese and overweight and who want to change critically. Lifestyle medicine is about behavioral change. And I think that one of the frustrations I felt really throughout my career was that light bulb moments that you mentioned earlier. That it's fantastic when it happens, when you see a patient's eyes light up and you think, wow, we hit on something there. And then the sudden realization, well, actually, yes, I can send you to somebody who can help, but there's a 6-month waiting list. Well, most lights don't last that long. Mm-hmm. And so it's lifestyle medicine, if you like, allows you to cope with that light bulb moment much better as a consequence of that approach, or having people that have the same approach within the practice or the environment in which you work. So I think that obesity is a big challenge, and in terms of how we deal with it. Well, that's another story. But
do you have a story about one of these successful light bulb moments in your patients that you've yeah? Well,
there's one that I do quote because I've got permission to do so. It was a light bulb moment, I think, for both patient and doctor in this case, that a patient came in to see me whom I hadn't actually met before. But it was a practice that was open. You could go and see whoever you wanted. And I had a look to see what his story was, and he had a neuroendocrine tumor with metastases and high KI index. So he wasn't in a good place. And he'd had 2 rounds of chemotherapy. So I knew all of this before he came in. But when he came in, I was expecting to be talking about that. But he talked about something completely trivial, nothing to do with it. And his wife wasn't with him. He was on his own. And so I asked him, well, and how is your wife and how are you? And his eyes welled up and he couldn't speak. And then he got up and walked out. I'm thinking, what did I do? So the next thing, he phoned up the reception and said, I want Dr. Lawson to come and visit me. I'm thinking, oh. And then he followed it up and said, I'm telling my oncologist that Dr. Lawson is my new doctor. I'm thinking, well, no, we're in the practice. So the next thing is that the oncologist rings me and says, effectively, Neil has got 6 weeks to live. There's nothing more we can do. And that's what you're going to have to tell him. And I'm thinking, When I went round to see him, I was greeted at his door by his 12-year-old daughter, who opened the door, and standing behind was his wife. Apart from having to take my shoes off, I think at that moment, seeing them opening the door, my light bulb moment was, this guy isn't going to be ready to be dying. This is, the idea of me saying to this guy, you've got 6 weeks to live, is not going to happen. So I went up the stairs to his room. He had a lounge and he was lying, he was cahectic, he was looking at a big screen, which is his present for himself. And I just sat down next to him and they just started chatting. And at one stage, I just held his hand quite naturally and he was quite receptive. And I began to get an idea of what he wanted. And that's when I saw something in his eyes. He had that light bulb moment, thinking, I can get through this. You could almost see it in his eyes. We can get through this. I can get through this. So the agreement was that I would go away and find out if there were any trials going on at the moment that he could maybe get into. And well, in those days of internet, it's the early days, but I stayed up and I looked through all the trials, and there was one finishing up in Glasgow. And I went back the next day to Neil and I said, there's a paperwork, go and ask your oncologist to give you that. Now, he did go back and he summoned up all the energy he had because he was thin as a rake. He slammed this down on the desk in front of the oncologist and said, I want that. And to her great credit, the oncologist didn't say, no, go away. She said, oh, well, maybe we can try something different. And she did. But we had already discussed that there were other ways to deal with this in addition to the chemotherapy. So he was signed up to the notion that physical activity was important as he got stronger. He absolutely understood the need for nutrition and got a book by Beliveau called Cancer. Is it Cancer for Food or something? Food for, I can't remember. It's Richard Beliveau in Canada. He'd got that, and his wife started to make these meals, mainly plant-based, I think. And he didn't touch alcohol, he didn't drink, he didn't smoke cigarettes. We know, that moment of arriving, seeing the daughter and wife there, and talking about his family. He was a twin. He had that love and support that he needed, and crucially, he had a supportive employer, and his employer clearly took a step back and did not reduce his income or anything or put that kind of pressure on him. Now that was 10 years ago. And from being 6 weeks to live, he's got no sign of tumor anywhere. He's completely free. He's had a PET scan, no sign of tumor. And I meet him for a green tea occasionally, and he's a picture of health. And this is a thing, why did he survive? And why aren't we interested in the fact that he survived? What did he have that made the difference? And what did he have that we can apply to other patients? And I think that's another irritation to me, is that in terms of trials, we tend to rely on randomized controlled trials, for example. You can't apply that in normal life. You really just can't do it that way. So why not set out to prove something doesn't work rather than something does work? But drug trials are nice and easy. You do them and you get an evaluation. It's very difficult in the real world with physical activity or stress or sleep or anything else. And so what the patients want is, what is it that will make a difference to me? And the sort of things that make a difference to them, we as doctors and other healthcare professionals are not knowledgeable enough to be able to tell them about, because we're pushed in this pharmacological, the non-drug side of things just simply doesn't really see the light of day. There's no money behind it. There's no research money. And to get back to your point, it's not sexy. So researchers aren't that interested.
Wow, I mean, what an incredible story of Neil, and so good to hear that he's doing well. But this story just brought out all the different aspects of lifestyle medicine. You mentioned his employer, you mentioned his family support, his social connection, and obviously he had you as his doctor who cared enough to stay up all night to do all the research and managed to convince his oncologist to try something else when they were about to give up. And you mentioned about the kind of the other determinants beyond the 6 pillars in lifestyle medicine. And earlier as well, you talked about inequality and how that affected the members in your the charity Live Well East Lothian. And COVID, the COVID pandemic has actually shed some light on these wider determinants of ill health. Can you elaborate more on what these are and why they're so important to address?
Yeah, I mean, the social and environmental determinants of health, I mean, everybody knows that they're there. Some people are in denial that as the front line that we can do anything about it. And I would contest, I do contest it. I think that is entirely wrong. It's not a binary thing, this. You know, just because somebody happens to live in a poverty-stricken area, why would you not want to help them? You know, it just doesn't make sense to me. And I think that the people that need it most are in precisely that environment. And lifestyle medicine can reach into that, especially through group consultation modeling. We know it can work really well in terms of getting to this change bit, that if people want to change, they will change. There are others who are in the pre-contemplative stage. If they come into a group setting, like a group consultation, and they're, somebody too along has changed their life around by making simple changes like stopping taking fizzy drinks throughout the day because they've got diabetes, they think, oh, maybe I should do that. Another light bulb moment that comes from another patient, not from the doctor or the clinician. So I think that, and certainly I've witnessed many consultations, group consultations in very deprived areas, again, it's so inspiring, and the learning that goes on is amazing. But how do you can't do a randomized controlled trial on it. So it's a question of slowly getting the evaluation and getting it out there. So I think that the other health inequalities environmentally, as I say to people, if you've got, for example, diabetes, the chances are you've got obese, you're overweight for type 2 diabetes. And that's the canary in the coal mine, as Gary calls it. And if you look upstream from that, and it's these upstream determinants, that if that obese person, well, maybe they're obese because they're very stressed, or they're very anxious, or they're depressed. And then you look a bit further up when you find, well, actually, maybe they're stressed, anxious, or depressed because they live in a house with 6 other people in 2 rooms, and they don't have any access to green space. And then you look a bit further up and think, well, maybe all of that's in place because they don't have a job in the first place. So if you don't look at your upstream, you're going to miss the point. I think that an example I can give you, and it happened a lot actually, in the town that I worked, a lot of old Victorian buildings are beyond, so they got damp, and the mold would grow on walls, and somebody would come in and they'd say that they had a streaming nose and sore sinuses and were coughing and sneezing and they felt a bit breathless. Well, no, you don't have asthma. Maybe it's something, where do you live? What sort of environment do you live in? How many doctors would start that conversation? And that's what we need to be doing. We need to be always thinking upstream and not say, oh, that sounds like asthma. Here, take this inhaler, go away and take this antihistamine, and I'm sure you'll be fine. No, we've got to stop and think, what's causing it and what can we do about it? So I got very good at writing letters to the local council on their behalf until something was done about it. So I think that we can make that difference at that one-to-one level. But we do have, I think, we have the moral authority as healthcare professionals to work at it upstream as well, and to influence our community and get involved in our community. For example, like you have, setting up a charity or whatever, to get involved, get the community involved, and then begin to knock on the door of policymakers further up the chain. It's not an easy task, but I don't see that, as I said before, a binary thing. It's something we can all do, and but we have to choose to do it. So yes, I think the social inequalities thing is something that I feel very strongly about, and I certainly don't think should be dismissed in any way. or attached to lifestyle medicine in any negative context is absolutely the opposite, in my view. And we've got to bang the drum about that, because there are people out there who try to put us down.
You talked about knocking on doors of policymakers, and I know that you wrote an open letter to the Prime Minister in 2019, explaining about these wider determinants of ill health, and you offered some solutions to stem the tide of chronic disease. Did you have any response back from them?
No. No, the answer is no. Nor did I honestly expect one. But we've also been in touch, because there's the new institute being set up down in England. We did send a letter there saying we'd quite like to get involved, to Chris Whitty as well. Sadly, we've just been kicked out of COP26. We had put in a bid, a very good bid, I thought, but we've not been allowed into COP26, which is a shame. And that was our own, along with our European Lifestyle Medicine Council. But in terms of what we do, where the answers are, I think that Gary Egger sent me a slide. I've got it, I think I've put it somewhere. Yeah, the strategies. He put a slide up, which I embellished a bit, but it basically explains that lifestyle medicine sits between public health and conventional medicine. I was speaking to Richard Pinder of the Imperial College, Imperial University in London, University College London. And he, interestingly, coming at it from a different angle of public health, saw lifestyle medicine as the clinical arm of public health. And it's not, I'm obviously coming at it from the other direction, but it makes a point. It is, there is an elastic connection between the two. But as Gary says, we legislate, we regulate and advocate where we can. We educate, motivate, and instigate where we can't. And we medicate, operate, or palliate if all else fails. And my worry is that we spend an awful lot of time dealing with failure. And we need to be thinking more widely at societal level and beyond, policy level in particular.
Absolutely. And what you said just before that, it's our job to advocate for our patients. It's so hard to do it in such a short time. And it almost feels like our 10-minute consultations and the 4-hour waits in A&E is all pushing us towards burnout and dissatisfaction with our jobs to such an extent where we are feeling that we can't even advocate for ourselves. It almost feels like a conspiracy theory to how stop doctors from advocating for their patients. Does that feel like that to you sometimes, or?
Do you know what? I think that inertia is a powerful thing, but it is a power that we can harness. So I think that if you feel that there's inertia there, we can harness that and put it back to them. It is worth persevering. Don't give up. Be stubborn. And the important thing from the point of view of any healthcare professional, whatever we do might not make a huge difference. And especially as a doctor, reflecting back over 30 years as a NHS practitioner, writing prescriptions, I'm thinking, what did I do? What good did I do? And my conclusion is that actually a lot of people do a lot of good simply by having a trusting relationship with their client or with their patient. That trusting relationship is huge. I think I'd just like to bring actually one of the most important facets of lifestyle medicine, or just simply being a doctor, knowing some research which is relevant. And I know I quote this a lot because I believe very strongly in it, that there are two studies to mention. One is called the Longevity Project, which was started about 80 years ago by Dr. Terman, who was a psychologist. And he recruited school children from the West Coast of America to follow them through life. And the idea was to see, well, what is it that led to a successful outcome in life for these pupils? And at the other side of the States, the Harvard Study of Adult Development, it compared two cohorts people from the tenements who were obviously less well off, and the Harvard elite. And they were looking to see, they asked at the onset, what is it do you think that will lead you to have a long, healthy life? And the Harvard elite, of course, said fame. And the Boston cohort said money. Well, lo and behold, neither of those are true. That on both studies, are still ongoing, but they came to much the same outcome in terms of decision. The outcome was death, obviously, and so you can't argue with that. The bias is taken out of the equation. But the thing that shone out was this having purpose in life. That was the number one thing by a long way, was having purpose in life. And that's, if you think about that inequalities thing, that we have a group of people, a cohort, a demographic in this country who don't have that purpose. And so they are therefore much more vulnerable. Now, the other thing that came out was that the people who did best also had somebody that they could trust to chat to work with, whatever, that trusting person. Rather like the Japanese moais in Okinawa, it's that notion of togetherness. And the other thing, of course, was being part of a community. So these things, blood pressure, cholesterol level, nothing to do with anything. It was these things that were important. Oddly enough, the personality trait that did best was somebody who was conscientious. So whatever route you took, and the paths went all over the place, these were the characteristics that led to a healthy, long life. Now, we're only here once. I'm sure I heard one of you say that before. So why not try and make the best of it? Let's help other people make the best of it, as well as for ourselves. So anyway, I hope that kind of makes sense.
Absolutely. And also, it makes sense why we decided not to quit medicine when we figured to go into lifestyle medicine, because you gave back purpose to us. Our purpose now is to bring that health that we always thought we would give when we signed up to medicine, and to bring that into our community, and that community brings that energy back to us, and this cycle goes on. So thank you so much for giving us purpose again. It definitely keeps us going, and when we wake up every single day. Very emotional, sorry. Before we move on to our informal group consultation part of afternoon tea, for those who have joined us here on Zoom, would you inspire our guest, Dr. Lawson, with 3 actionable and practical takeaways that they can implement right away to take control of their health?
So you're asking me to give 3 actionable, oh gosh. Well, let's say, physical activity is an easy one. Just increase your activity level. Doesn't matter what you do. You don't have to go to the gym. We're not asking you to take up running or cycling or, goodness me, wild water swimming. But just be more active. See being active as an opportunity, not a threat. In my case, I've just simply, and the reason I'm standing now is I've got one of these desks things that goes up and down. I think that be less sedentary, be on your feet more. So that's number one. I think that's easily done. You just need to, I'll tell you a funny story. I was in the American, for the American College of Lifestyle Medicine. I've only been once, but I was at their conference, and it was in one of these typically massive places, and it had moving stairs in the middle of ordinary stairs, And I just thinking that, well, this is a lifestyle medicine conference. I'll be really interested to see how many people use the stairs and how many just stand and all the way up. And I was actually quite shocked that so few people use the stairs. So I think that when faced with this option of moving a staircase or the chair, take the stairs. That's number one. What else? Food. What actionable point? I think it's worth working out from day to day what you're putting. In fact, you could almost photograph everything you put in your mouth and then look at the photographs and think, is there anything there that maybe I should, it'd be better not to be eating, and there's something else I could take in its place. I think that my biggest tip would be cut out and reduce processed foods as much as you can. If you can recognize it as food, that's fine. But if it isn't obviously food, think twice, read the labels. That would be that. The third thing probably is to do with sleep. That's one thing. When I set up 30 years ago my lifestyle active management program, sleep wasn't part of that. I didn't know anything about it. But now we do recognize the importance of it. So I think that staying away from screens for a couple of hours before your bedtime, just reducing blue light, not hard to do. Pick up a book and read an old-fashioned book or something. Just sit quietly, and hopefully you'll get to sleep really quickly, or take a bath or something, But I think that switch off your tellies and your phones and your computers a couple of hours before you go to your bed, and get a good night's sleep. So I suppose those are my, off the top of my head, 3 things.
3 things that I try to follow as religiously as I can, and they certainly help. Putting sleep first actually kind of helps to make the right decisions through the day, I found. So if you are a healthcare professional and would like to take the lifestyle medicine diploma, check out British Society of Lifestyle Medicine, which is at www.bslm.org.uk. The diploma will be at the end of this year. I think it's going to be in November, right? The exam itself.
The exam is between the 27th of November and the 11th of December, and it will be in a prometric test center near you. 60 days before the exam, we have to give the list to them and the international board, and then it's between the candidate and the prometric test center as to when and where they go. So that's a change from what we've had in the past.
Right. And when is the British Society of Lifestyle Medicine conference this year? 2nd
to 4th of September. Really very excited about it, because a lot of great speakers, very important speakers, and the spread, of course. We've got a sculptor who's coming to talk as well. I mean, I like the arts. I was always so much better at the arts than I was at sciences. I don't know why I ended up doing medicine, really, but I'm really delighted to have a sculptor coming to talk about open spaces, environmental sculptor. And we've also got a patient actually to talk about his melanoma journey. And he's actually very well known and has done a film about it. But then, of course, we've got people like Tim Spector, and we've got a couple of dames, important people. Well, even Gary's going to have a cameo. We've got a whole range of speakers from around Europe as well. And Kate Collins is coming over from the US.
Wow.
Well, we'll see if she comes. She will be presenting anyway. So there's a whole range there, and one of them, for example, one of the speakers is a town planner, and a healthy town planner, to deal with that sort of environmental thing. How can we design new towns that are actually going to help us and create the environment for us to lead healthy lives? Because it's not, lifestyle medicine isn't a blame thing. We're not blaming anybody for anything. What we want to do is to create an environment where people can make healthy choices. That's all. It's not rocket science. When planning a new town, let's plan it in from the beginning. Have everything there that keeps us healthy. So yeah, there's a whole range of speakers, and thanks for bringing that up. That's an important, very important conference.
Absolutely, and we're so excited for it to come, and also to visit beautiful Scotland. It's a great opportunity to do so. And as you said, with the town planner, is so important, because it is the root cause of the problems that we are seeing. So we really have to buckle down and get our environment as healthy as possible. So super exciting. Next Sunday, we will be hosting Dr. Hans Steele, founder of the Complete Health Improvement Program that has changed the lives of thousands of people over the last 30 plus years by re-empowering them to regain control of their health with the lifestyle medicine principles that we have discussed here. you can book your free tickets through our website, and we hope to see you there. Do stay connected with us on social media and say hello on Instagram, and subscribe to our YouTube channel where you can rewatch this incredible talk with Dr. Rob Lawson. The links are here below in the chat, and also you can check it out on our social. Our May events are dedicated to raise donations to help India breathe. If you enjoyed this session, please consider donating to our Just Giving site that supports the incredible charities on the ground, bringing oxygen and food to those most in need. The donation link can be seen here in the chat, or if you're watching on YouTube, then you can find it in the description below.
And you can become a free Afternoon Tea with Docs member on our website to continue this conversation and to join the supportive community, helping you implement the healthful lifestyle changes you want that will help you live a long and fulfilling life. Please do comment in the chat your thoughts and feedback from today. And for those of you watching on YouTube, please do comment below and let us know how we're doing. Thank you for listening and have a lovely evening. So we'll stop the recording now.